Hi guys. Hey Jay. Hi James.
Hi,
Thanks,
Tom.
Emily. How are you?
How are you?
I'm doing good. I'm doing good. Thanks for you know chiming in. Hi Tashina.
Hey, Dr. Mounzer. Hey,
How
Dr.
are you?
Kostman. I'm good. Hello, 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 everyone. Welcome to week 4 of the Prevention Summit, HIV and Prevention Summit. And today we have a special presentation by our very own doctors at Philadelphia Fight. And the webinar is entitled A New Era of Medications for Addiction Treatment, a focus on long-acting agents. And so I'm excited to have you with us to share on this important topic. But before we get into the conversation, there are a few things that I need to let our audience be aware of. For starters, our chat box has been disabled. You can ask your questions or post a comment or concern in the Q&A box. At the end of our webinar presentation, we will then get to your questions at the end of the webinar. So again, thank you for choosing to spend some time with us this afternoon as we engage in this important topic. So I'm going to pass the mic to Emily.
Hi, thanks so much. I am going to share my slides. Okay, just verify that I'm sharing my slides. Dr. Mounzer, can you see my slides?
I see your slide.
Excellent. Okay, thank you so much. So our team is here to talk to you today about a new era of medications for addiction treatment, and we're specifically focusing on long-acting agents, or also known as long-acting injectables. So I'll introduce each one of us. I am Emily Loscalzo. I'm a clinical psychologist and master addiction counselor, nationally certified clinical supervisor, and I'm the director of harm reduction services here at Philadelphia Fight Community Health Centers. I'm also here with Michael Leonard. He is our brand new certified recovery specialist here at Philadelphia Fight, and he also has an Associates of Science. Also, Karam Mounzer is with us. He is the Chief Scientific Officer here at Philadelphia Fight, as well as Clinical Professor of Medicine at University of Pennsylvania. Jay Kostman is our Master Clinician here at the John Bell Health Center of Philadelphia Fight. And we have a special guest, James, with us to speak about lived experience. So I will just begin by giving the scope of the issue of opioid use disorder. Overdose is most commonly associated with speaking about the opioid crisis, overdose epidemic. So the and that's because the most common type of drug overdose comes from opioids. It's one of the major public health crises of our time, and there have been more deaths in Philadelphia than car crashes and homicides in recent years from opioid overdoses. In 2017, there were 1,200 plus deaths due to opioid overdose, and it's been rapidly rising in the past decade. Has definitely been rapidly rising ever since COVID began, and the racial and ethnic inequities in the overdoses have also been really apparent. So how are these overdoses happening? In addition to the complications that COVID has brought to us, there's also been the rise in prescription pain medications. That has especially been a problem in rural areas, but also apparent in urban as well. The heroin problem, especially in Philadelphia, has been rising over the last couple of decades, and the addition of fentanyl over the last, I would say now it's been probably 6 or 7 years since fentanyl started, really creeping up in Philadelphia. That has also led to a slew of overdoses. So I'll get into like a little bit more about why. And there are some like pretty specific locations and associated trends within Philadelphia. Kensington is really frequently associated with substance use and particularly opioid use in Philadelphia, but there are other parts of Philadelphia as well that are affected. It's really widespread. So I also wanted to give an overview of how opioid use is so related to HIV infection. There's actually some pretty current news from the Philadelphia Department of Public Health, because unfortunately HIV infections have really been rising. Philadelphia is one of the 48 counties in the United States with the highest number of new HIV infections, and unfortunately just going up. After a few new diagnoses in 2020 due to limited access to HIV testing during COVID's early days, I should say, the Philadelphia Department of Public Health is now observing an increase in new infections among people with IV substance use, including men who have sex with men who inject drugs. During 2021, 59 new cases were diagnosed, which is an 84% increase in HIV diagnoses compared to 2016, when the lowest number of HIV diagnoses among people with injection drug use had ever been reported in the history of the HIV epidemic in Philadelphia. More recently, there have been 18 new cases diagnosed in the first 3 months of 2022. And unfortunately also seeing shifting demographics among people with injection drug use newly diagnosed with HIV. The proportion of cases has increased among white individuals, 64%, non-Hispanic Black individuals, 21%, individuals over 30, 90%, and among males, 80%. So if new HIV diagnoses continue at this pace, 2022 will far exceed new diagnoses in 2020 and 2021. Since 2016, 353 cases have been diagnosed among people with injection drug use and people with injection drug use that men who have sex with men. So substances, I just also want to talk a little bit about opioids to give a little sneak preview for some of what Dr. Kosman and Dr. Mounzer are going to be discussing. So to give you a sense of what they are and why people are, so like become so addicted to them, substances chemically related to and interacting with opiate receptors in the nerves of the brain are considered opioids, and they produce a pleasurable effect and relieve pain. Used for pain relief and anesthesia in the medical setting, some of the prescriptions that you might have heard of are oxycodone, hydrocodone, codeine, morphine, and we also hear of fentanyl and methadone in the medical setting as well. Fentanyl we also hear of in the illicit sense as well, but it can be used safely for medical purposes. Heroin is the other non-prescription opiate that we hear about most often. So most people who use heroin are also using at least one other drug either concurrently or have throughout their lifetime. Some of the other drugs that are frequently used are, along with heroin, are alcohol, benzodiazepines, which are pills, tranquilizers such as Xanax, Valium, Klonopin, marijuana, cocaine or crack, and other opioid pain medicines. Many people end up beginning with heroin because they end up transitioning from prescription pain relievers to heroin because it is cheaper. They've been cut off by their physician from prescription pain relievers, but they're in withdrawal. They still need something on their opiate receptors to avoid that withdrawal, and because it's incredibly painful. So a lot of people end up buying from the street in that case. I know that I had mentioned fentanyl and how dangerous it has been in terms of overdoses and the opioid crisis. It's a synthetic opioid that was first presented to the drug market in 2006, came back. It's actually made a couple of comebacks over the last couple decades, unfortunately, and it's been a part of the ongoing drug overdose crisis here in Philadelphia. That is because it is 50 to 100 times more powerful than heroin. And occasionally we also see carfentanil, which is an elephant tranquilizer. So this is used in the veterinary setting and is 10,000 times more powerful than heroin. So, we're seeing a lot more of what dangers unfortunately accompany opioid use. And just to give you a visual of heroin versus fentanyl versus carfentanil, these are equivalent amounts. These are all lethal doses of each drug. And, there's like a smattering of heroin, some like fine grains of fentanyl that's equivalent to that, and really like only one tiny grain of carfentanil that is equivalent. So a lot of people are dying tragically from this disorder, unfortunately. So just to set things up for our other speakers, just one more little overview about opioids, medications for opioid use disorder, and how this can prevent overdoses and new HIV infections. So since the brain has many receptors for opioids, and these, act as sort of like keys turning in the receptors, that is what releases this feeling of intoxication throughout the body. And too much of this can lead to overdose. The high prevalence of HIV/AIDS among people with opioid use disorder has led to several evidence-based approaches being developed in order to reduce the frequency of risky injection behavior among those who are at risk of HIV infection. So what these two things have in common is medications for opioid use disorder can both prevent overdose and help prevent new HIV infections, because people who take these medications are able to reduce their cravings and use less, or actually cease their opiate use, as that is the goal for many people too. So I will turn it over to Dr. Kosman to give us some more details about medication-assisted treatment for substance use disorders.
Thanks, Emily. Appreciate it. So I'm going to talk about how we can approach the treatment of opioid use disorder using medication-assisted treatment, and specifically try to highlight the long-acting agents which are now being used to treat the disorder. You might need to advance me, I think, when I go forward. I'm not sure.
Yeah, just let me know when
you'd like. Thank you.
Thanks.
Yeah. So first thing that to just in terms of overview, and really bottom line is that medications for opioid use disorder save lives. And they save lives by preventing overdose for one thing, but they also save lives by preventing some of the complications of opioid use disorder and continued use, such as HIV infection and chronic hepatitis C infection as well. And so the three major medicines that we'll talk about are, and we'll talk about the differences between these, are buprenorphine, which can be given either as an oral or sublingual component with where it's combined with naloxone, or methadone, or extended release naltrexone, trade name Vivitrol. The trade name for the long-acting version injectable of buprenorphine is what I'll talk about, is called Sublocade. And I'll use trade names as I go through with some of these. In addition to saving lives, the use of these agents also increase retention in treatment as well. And so their goal is really to keep people from using heroin and fentanyl, as Emily described. Next slide. And so really the benefits of medications for opioid use disorder can be summarized in this slide, that they decreased mortality. This is from a summary of 3 different studies over the last 5 years or so, looking at standardized mortality ratios in the general population and in people who have a history of opioid use disorder and those who are on medication-assisted treatment. And you can see the dramatic reduction in death rates in those who are on medication-assisted treatment compared to those who are not on any treatment. Next slide. So let's focus on the 3 agents, really 2 agents that we're going to talk about, and that's naltrexone and buprenorphine. Next slide. So, and I know Dr. Mounzer is going to talk about this as well when he talks about his project and the effects on HIV reservoir by using medication-assisted treatment. But just to introduce this concept, so the agents that are used as agents in medication-assisted treatment for opioid use disorder can be broken down into sort of 3 categories. We have the partial agonists, where there is partial opiate activity without respiratory depression, where there's a limit on analgesia, and there's preventing opiate withdrawal, blocking the full agonist effect. And then there is a pure antagonist, where there is no opioid activity and complete blockade, compared to the effect of a full agonist, where there is full opiate activity resulting in respiratory depression and analgesia. Next slide. So let's talk about these 2 agents. So buprenorphine is the partial receptor activator. And the treatment goal when using buprenorphine is to activate the opioid receptors to the point that a person who is on it doesn't experience opioid cravings and is not experiencing withdrawal symptoms. The duration of action of, the sublingual or oral drug is about 24 hours. But there is a long-acting form, trade name Sublocade, that is given as a monthly injection. And that's really introduced a whole new approach to using buprenorphine in the treatment of opioid use disorder, because Suboxone or buprenorphine combined with naloxone orally has to be given at least every day, if not twice a day, whereas the injection is a once a month injection. And so you don't have to, when you're giving patients this drug, you don't have to talk to them about taking something every day. So it's the same concept in terms of the pharmacology, but the administration is really a marked difference. Regardless of how it's given, it has a very high affinity for receptor sites and will kick most existing opioids off of their receptor. And so what that means is if there are existing opiates around, you can precipitate withdrawal and by using this drug. But there is the so-called ceiling effect, which makes it very safe for opioid users. Next slide. So when it's given orally, and I should say when we're using Sublocade, which is the long-acting injectable formulation, you're generally starting people who have been on the usual oral dosage of the drug. And I think it's important to mention that this is not something where you're just going to start someone on the injectable formulation. And so when you're using the usual adult dosage orally, they have to be in mild to moderate withdrawal prior to the first dose. And there is a dose escalation that is done as you're starting and as people tolerate the withdrawal symptoms, usually escalating the dose 8 milligrams per day up to, on average, 16 milligrams per day with an upper limit of 24 milligrams per day. As we mentioned, Suboxone is a partial opioid agonist. And really the contraindications for the oral preparation are a hypersensitivity to either of the components of Suboxone, either buprenorphine or naloxone, or in those people who have severe hepatic impairment and may have difficulty metabolizing the drug. The difference between Sublocade and Suboxone is a combination of buprenorphine and naloxone, which is a pure antagonist, whereas Sublocade is just buprenorphine, which is the partial agonist. So starting with the oral dose and then escalating and being able to change in a chronic situation to the long-acting agent, where it's administered generally in 2 monthly doses of 300 milligrams, followed by a stable dose of 100 milligrams monthly for as long as the person is on Sublocade preparation. Next slide. So the other long-acting alternative is naltrexone. And naltrexone, in contradistinction to buprenorphine, which is a partial agonist, is a full receptor antagonist, which reverses and then caps the opioid receptor, structurally similar to naloxone or Narcan. So the treatment goal with naltrexone is to remove the ability to use any substance by removing the euphoric effects of taking whichever the opiate substance is. And so you can see in the picture that naltrexone, trade name Vivitrol, when it's given as the long-acting agent, completely blocks the receptor so that the opioid, you don't get the effect of any administered opioid. As an aside, naltrexone or Vivitrol is FDA approved for both opioid addiction and alcohol addiction as well. And although it's available as an oral tablet, it is most often used as an extended release injectable. And that's the trade name is Vivitrol. And the advantage to the injectable form is it markedly increases treatment adherence because you don't have to take an oral preparation every day. It's an injectable form that is given every month and actually has a tail in its pharmacology so that it often will last even more than the 4 weeks when it's administered. Next slide. I think we might have skipped one. I'm sorry. So generally considered as ideal candidates for extended release naltrexone, individuals who are highly motivated and well supported in their recovery and have a safety net, individuals who might continue to work in professions which might prohibit the use of other MAT medications, and individuals who have already gone through a detoxification period and might be opposed to any partial agonist theory, like as would be present with buprenorphine. And as I mentioned, because it's also approved for alcohol use disorder in people who have dual disorders, it might be particularly useful. Next slide. And so the precautions with Vivitrol or naltrexone, advanced hepatic disease or renal impairment, if opioid analgesia is needed in people who are on naltrexone, larger doses may be required, which may deepen respiratory depression. If the patient is dependent on opioids and is given naltrexone, you will precipitate severe withdrawal because of its mechanism of complete blockade. And then there are also some side effects noted with administration of the drug, some of which are linked to withdrawal, including nausea, vomiting, but also headache, as well as some disease. And the major drug interaction is with other opioids. Next slide. So how do you choose between the two? Not taking away from Dr. Mounzer and how he's going to highlight potential differences in his work, but naltrexone or Vivitrol is not a controlled substance. There's less intensive monitoring that's needed. With the injectable version, there's really no risk of diversion because you're not using an oral agent. And the long-acting injectable allows for that. People have to be abstinent for 7 to 10 days before starting naltrexone because of the risk of precipitating withdrawal. And there is recommendation to monitor liver function. Next slide. In terms of buprenorphine, it is a controlled substance. It's a Schedule III drug, and a prescriber has to obtain additional DEA certification in order to prescribe it, which is different than Vivitrol. And those additional approvals limits the number of patients that each prescriber can maintain. But it can be given an advantage, particularly with the injectable form, can be given in office-based opioid treatment settings rather than in treatment programs that administer methadone, for example. And there's lower risk of abuse or diversion, although there is still some risk, but that risk of diversion goes away when using the long-acting injectable form, which is one of the major advantages of that. And so particularly compared to a drug like methadone, it may be a better option for patients who can't attend a daily dosing clinic. Next slide. And in terms of effectiveness and comparative effectiveness, this just sort of summarized some of those things and compare the ones on the left with the ones on the right, long-acting naltrexone or Vivitrol with long-acting buprenorphine or Sublocade. No abuse potential with Vivitrol. There is complete opioid blockade with no pleasure. You do have to have 7 days of opioid-free time And whereas with buprenorphine, and particularly with Sublocade, it may be better in people with complex medical conditions, and particularly there's more access in an office-based setting, including in rural settings with minimal risk for overdosing. Next slide. You tell if this approach is working, if there is a stoppage of using other opioids, there's decrease or removal of craving for opioids. There's no withdrawal symptoms and no side effects from the medications, with the end goal being that a patient who is on either of these agents feel like they have more control over their life and that they're not out of control due to their opioid use disorder. Next slide. I think that might be it.
Rick, that's it. So
yeah, thank you.
Thanks so much, Dr. Kosman. I am going to stop sharing my screen, turn it over to Dr. Mounzer, who is going to talk to us about MOUD, opioids and HIV, and their interplay and impact on the immune system.
Well, thank you, Emily. Thank you, Jay. And thanks everyone who joined us today, although virtually. Again, my talk is revolving today around the interplay between opiates, medication for opiate use disorder that Jay alluded to extensively in his talk, and HIV, and how those interplay impact the immune system, specifically how the interaction between these factors really leads to immune activation, which is bad news when it comes to HIV, because immune activation potentially can lead to an expansion of HIV reservoirs. So this is my talk today. There is emerging evidence that opiates and certain medication for opiate use disorder can lead to an increased immune activation, which, as I mentioned to you, can fuel and expand the hidden HIV reservoirs among patients living with HIV. And we're gonna literally go over the mechanism that drives this, and eventually how that could potentially impact the treatment of opiate use disorder. Before we get there, I would like to walk you through the mechanisms that drive the immune activation or the interplay between opiates, medication for opiate use disorder, and immune activation. As you know, the mu receptors play a key role. The mu receptors are spread out in the brain, in spinal cord, peripheral sensory neurons, but also in the intestinal tract. And literally, they are all over the GI tract. They start in the stomach, the small bowel, large bowel, the gallbladder. And when you activate these mu receptors via opiates or medication for opiate use disorder that have opiate agonist activity, technically you bring the GI tract to almost a full stop. Really, the stimulation of these mu receptors decrease significantly the motility, the secretion of the GI tract, and that leads to literally a slowing down, stagnation of the GI fluid in the GI tract, and that leads to bacterial overgrowth, distension of the bowel that can lead to really that can compromise the integrity of the GI tract, of the mucosa of the GI tract, and that can lead to translocation of bacteria. So there are millions of bacteria living in the GI tract. Some of these bacterial debris can translocate through the GI tract into the bloodstream, and that can lead to systemic inflammation. So this is what we call bacterial translocation, and there's no question that opiates have a direct impact on the microbiome, which is, you know, the bacterial balance in the GI tract, and then can also impact bacterial translocation. That has been shown in mice models and also in human models. And the translocation of this bacterial degree we can measure it in the bloodstream because there's a lipopolysaccharide. It's derived from these micro debris, this bacterial debris that can be measured. And it can directly stimulate the immune system systemically and cause inflammation as well. Now, so the interplay between HIV and opiate and specifically medication for opiate use disorder is emerging to be an important kind of like, to be important in terms of immune activation and subsequently bacterial translocation and the downstream complication that can lead to. So I'm going to walk you through a little bit of the synergy between HIV infection and medication for opiate use disorders and opiates. HIV, as you know, will ravage the GI system. Specifically, it will invade the the GI-associated lymphoid tissue, so all the lymphocytes that are embedded in the GI tract, and it literally invades those lymphocytes and uses them to replicate and destroys them at the same time. So it really triggers a significant inflammation, and it also triggers a decay, a destruction of this lymphoid tissue in the GI tract, which is a very important barrier of defense against bacteria that tends to colonize our GI tract. So that's an important hit to the GI tract. As I mentioned to you, opiates and mood tend to also impact the microbiome due to stagnation, bacterial overgrowth in the GI tract itself. And the two feeds into each other. So immune activation, inflammation of the GI tract leads with bacterial overgrowth, leads to really, it's a perfect recipe for bacteria to translocate from the GI tract into the bloodstream. And that's what happened. Bacteria and bacterial debris translocate into the bloodstream. And when they do so, they literally stimulate our immune system because our blood is loaded with T lymphocytes. And when they see those debris, this LPS kind of like in the bloodstream, they get very rattled and they get activated and they start secreting inflammatory mediators. And we know that chronic inflammation left unaddressed over time can lead to end organ damage. So some of the end organ damage that we encounter among people aging with HIV is due to the fact that they have this chronic inflammation in their system that leads to cardiovascular disease. It leads to metabolic disorders, i.e. diabetes, dyslipidemia. It can weaken their bone, chronic renal insufficiency, liver disease, fatty liver specifically. It can lead to neurocognitive impairment. And so this is kind of like, it's bad news. Chronic inflammation is bad news to our patients. And you can see this interplay between HIV and opiates and how that can really lead or contribute to this ongoing chronic inflammation. Now, as you know, one of the ways of really assessing chronic inflammation in the bloodstream is to measure inflammatory markers. One key marker is the soluble CD14, which signals an immune activation. It's really an immune activation of macrophages and monocytes in the bloodstream that secretes this mediator, and it correlates. It's a marker of bacterial translocation. So, the higher the degree of bacterial translocation, the more inflammation, and the higher the level of SCD14 in the bloodstream of patients. So it's a surrogate marker really of chronic ongoing inflammation, which can be triggered by bacterial translocation. In a proof of concept study, in a pilot study that was done in collaboration with the Wistar Institute and the leadership of Dr. Montané, Luis, we showed that patients living with HIV on antiretroviral therapy and were suppressed on antiretroviral therapy, we showed that those who have opiate use disorder and who had active opiate use disorder, when we looked at the immune activation assessed in both their bloodstream and in their GI tract, in green is immune activation. We're measuring specific cells that represent immune activation. These are activated T lymphocyte cells in the GI tract in green, and in the bloodstream. We showed that the amount of these activated cells is much higher among patients who are actively using, who have active substance use disorder compared to those who don't have active use disorder. And we also showed that the level of SCD14, which is the soluble CD14, which is surrogate marker of inflammation that really correlates with the degree of translocation, among other things, we showed that the level of inflammatory markers, specifically SCD14, was higher. And this on the right-hand side of this slide, it was higher among opiate use disorder compared to patients without opiate use disorder. So this is kind of like a very, very important observation. And I can tell you that that was kind of like a hypothesis generating finding that led us to design the study I'll be sharing with you momentarily. But before I get to that point, it's important that I show you kind of like a key slide looking at the correlation between soluble CD14, which is a marker of inflammation, immune activation, and long-term survival. As you can see, SCD14 is an independent predictor of mortality. The higher the levels of SCD14 in people living with HIV or non-HIV infected patient, the higher the risk of mortality over time. As you can see on the slide, in yellow and red, the curves, you can see high risk of mortality as encountered among people with high level of SCD14. So it's an independent predictor of mortality over time. So kind of like chronic inflammation, again, is bad news. So with that said, this is again to show you that not all medication for opioid use disorder are created equal. As Jay alluded to in his talk, you have full agonists like methadone, and really they are classified into three major classes depending on their activity vis-a-vis the mu receptor, how much they activate the mu receptor. Full agonists, really, they have full effect on the mu receptor, like methadone for treatment of patient with opioid use disorder. Partial agonists like buprenorphine, and antagonists like naltrexone. And the question is, how do they impact the degree of immune activation in patients living with HIV who have opioid use disorder? And again, in our pilot study, although it's a small n, the observation was pretty striking. What we showed is among our patients with opioid use disorder who were on methadone, the level of SCD14 was significantly higher. So the level of inflammatory markers in their bloodstream among patients who are on methadone was significantly higher than those patients who are on naltrexone, as if naltrexone doesn't really rattle the immune system, does not lead to immune activation. And the level of immune activation, the level of SCD14 was equivalent between those who had opioid use disorder on naltrexone and patients without a history of injection drug use, opiate specifically. So that was kind of like the hypothesis generating observation that led us to design the MOE study. And this is, again, in collaboration with Wistar, we're a site collaborating with our colleagues at Wistar. And MOE stands for Antiretroviral Therapy, ART, Mood, Medication for Opioid Use Disorders, Opioids, and HIV Infection, MOE. This study was funded by the NIH, the NIDA, which is the National Institute of Drug Addiction. This is a big project that we already started. And the purpose, the main objective of this process is to really assess critically the impact of medication for opioid use disorder, i.e. methadone, buprenorphine, and naltrexone, which are the three commonly used drugs to really help our patients struggling with opioid use disorder. The impact of these agents on gut immune activation, again, immune activation within the gut, gut integrity, the changes in myeloid activation. So, and how does that interplay with microbial translocation, and what is the net effect of all of this? How all of this can impact HIV reservoirs. As I mentioned to you, chronic inflammation, immune activation could potentially expand HIV reservoirs. So again, this is kind of like a schematic of what we're trying to do, is the impact of methadone, Suboxone, naltrexone on the microbiome in the GI tract, bacterial translocation, how that really impact inflammation of the immune, activation of immune system and inflammation, and all of this, how that really impact HIV replication, HIV reservoirs in people who are on antiretroviral therapy. So we're looking at the interplay of all these factors and how that eventually at the end will impact immune recovery in our patients living with HIV on therapy. So the study is pretty straightforward. The folks who are enrolling in the study, which is actively enrolling as we speak, are individuals who are living with HIV, 18 to 65. They have to be controlled virologically for at least 1 year, and they should be less than 50 at screening. And they have to be on medication for their opioid use disorder as listed. And important exclusion criteria is they should not have any ongoing AIDS-defining illness at the time of consenting and screening. They should not have advanced liver disease, i.e. cirrhosis of the liver, and they cannot be using stimulant such as cocaine and others. However, benzos and cannabinoids are allowed in our patients. So the study will really comprise 4 groups of patients, as we said, each one containing 30 patients on treatment for a year stable with substance use disorder, on methadone, 30 patients, on Suboxone, 30, on naltrexone, 30 patients. And then we're going to have a control arm of 30 individuals as well, who do not have a history of opioid use disorder and not on any medication for opioid use disorder. So this is our control arm in a sense. And the study is pretty straightforward. This is a cross-sectional study where we're getting, there are kind of 3 visits. The first one, screening visit, is to really assess the eligibility of our patient for the trial. During this study, we're getting basic labs. We're getting a FibroScan to ascertain patient don't have cirrhosis of the liver. And then once deemed to be eligible, patient will be scheduled at their convenience to come in for a blood draw, and this will take place at the Wistar Institute or at our site, depending. But again, this is an important visit because this is the visit where we're going to collect blood and run all kind of assays to assess immune activation, measure the SCD14, among other things, and many other inflammatory markers. And then they will be scheduled for a sigmoidoscopy at a third time point. They will be scheduled for an outpatient elective sigmoidoscopy with rectal biopsy. And the purpose of this procedure is to obtain tissue, one, to look at gut integrity, to make sure we understand that, but more importantly, to assess HIV viral reservoirs and to measure literally HIV reservoirs within the GI tissue, which is a surrogate of reservoirs all over the patient's body. So this is really what the study designed, and it's an important study again because it will help us answer a critical question, which is, among people living with HIV, what is really the best option to address their medication, their opioid use disorder? What is it naltrexone, which is which is an antagonist? Is it a full agonist? Is it a partial agonist? Because again, each one of these drugs tend to impact immune activation differently. And hence, there is a tremendous gain of using probably a drug that has the least impact on immune activations and subsequently the least impact on HIV reservoirs. So the purpose of the study could have a global impact if we can determine that one modality may be superior to the other modalities in terms of how it impacts immune activation and subsequently the expansion of HIV reservoirs. And with that, I would pass on the baton to our next speaker. Thank you for listening.
So much, Dr. Mounzer. You can stop your screen share and I will pull mine back up. And then I'll invite James, our survivor speaker, to come give us his personal account.
Okay, thank you, Emily. So good afternoon, everyone. I'm briefly just going to go over my experience with the once-a-month Subsequade shot that I've been taking for several months now. When I first initially took the Subsequade shot, I was coming off of a year-long treatment, almost a year-long treatment and rehab. Before that, around a 5.5, 6 year habit of heroin, doing it every single day. While I was in treatment for the first year, I was on the Suboxone tabs, which were mentioned earlier. And I was taking those once a day. So they were getting raised probably like every couple of months, the dosage would be. It wasn't until, I believe, around November of last year that a therapist of mine had heard about the Subsequade option and recommended that I give it a shot. And so when I was pointed to Philadelphia Fight, that's when I started taking Subsequade. And like I said, it's been several months now. And honestly, it does exactly what the two gentlemen had spoken about before. It does exactly that. I have noticed no side effects whatsoever. I feel pretty much normal. I don't have to take something every single day for the first time in years. And it was a little, I think, like The only thing about it is the actual shot itself is very painful, but that goes away after a few minutes. And it's given me some of my life back because I don't have to, get up and try and figure out what I'm going to do, or even as far as like in rehab, I don't have to take something every single day in order to not be sick all the time. So, yeah, I believe that's all I can say about it, unless there's any questions. But yeah, it's really turned my life around, and I'm glad I was turned on to it.
That's fabulous, James. So glad to hear that. Thank you so much. I will now turn it over to Michael Leonard, our certified recovery specialist, so he can tell us about the importance of peer support in the treatment experience.
Thanks, Emily. Good afternoon, everybody. My name is Michael Leonard. I'm the certified recovery specialist here at Philadelphia Fight in the Harm Reduction Department. I'm here to talk about the importance of me as a certified recovery specialist tying into everything that everybody before me talked about. There with the clients or persons that we deal with, there is a time when a shift takes place, and the shift is from their focus on addiction to their focus shift into recovery. And as they go through that shift, that's where I start to come in and show up and assist with, I would like to call them as they are, and their peer-based recovery services. The most important thing that I try to do as I meet these people and start to engage with them is I first try to assess their recovery capital, and recovery capital is all the ingredients that go into what we normally would call our lifestyles, like our finances, our housing, our health, our mental health. All those kind of things are what we consider recovery capital. And sometimes, and a lot of times, coming from substance use, a lot of those pieces of capital don't exist, or they've been discarded along the way. And it's funny because the picture that Emily has up, it's got all these little pieces that's missing. And what recovery capital and the CRS tries to do is once I can assess your recovery capital, then I can start to fill in the gaps if there are any, or start wherever your recovery capital starts at. And as the certified recovery specialist, while doing that, I start to figure out, okay, how to introduce to each person, client, what pathway might be good for them. Now, I don't make that choice for them. They make that choice for themselves. But my role is to introduce them to every venue that could possibly help them move forward in their recovery. Because everybody doesn't recover the same way. Everybody doesn't require the same things or want the same things to recover. Everybody recovers to a different extent. So it's all up to the individual. And that's why the recovery plan is a collaborative effort between myself and the client, because I'm not here to dictate to a client which direction they should go in terms of their recovery. I'm here to assist them with the recovery path that they choose. And in doing that, I start to see where I'm best needed and how I can assist. And a lot of it comes down to not only assisting, but sometimes subtly directing. You know, you don't tell people what to do, but sometimes you suggest things for them to do. And as you work with the person being the lead in their life and what they want in their life and how they want to go about getting it, then that's where I come in at. I just try to shadow their wants and needs and assist them wherever I can as they start to rebuild their lives. And it's not always an easy task, but there's always a starting point. And, you know, wherever that point is, that's where you pick up from. And, you know, everybody presents a whole different situation. So the work is not only sometimes challenging, but it's also very exciting, you know, because, you know, a lot of how I connect with them is through lived experience. And it's something about when you can touch bases with a person on empathy and they understand that you understand. It makes it a whole lot easier as you start to make suggestions and subtly, like I said, guide and, you know, just put together a plan, because the plan, the recovery plan that is put in place, it is for whether you continue on with your medically assisted treatment, because treatment is a part of recovery. You know, it's just one phase of it. And it's for whether you continue on with that in a long term or if you stop it, you know, because there are stages of recovery that start with pre-contemplation, but it ends with maintenance, which means maintaining your recovery. So the recovery plan exists after all the medication is gone. It exists whether there's medication there for the duration. And, you know, I think it to be important work because when you're coming out of some of the places that you can come out of as a result of substance use, like you most times you're lost, you know. And one of the main things that individuals need most from the door is hope, you know. And as I talk to them, that's what I try to give them. Try to let them know that I'm proud of what they're doing, where they at. And in doing that, they start to open up and reveal to me where they really at. And once I can get to that part, then I can start to put the other things that a certified recovery specialist truly does into place. So that's my little spiel on the importance of peer support. You know, it has a role, just like everything else has a role. And I thank everybody for their time this afternoon. Thanks.
Thanks so much, Michael, for the work you do. And thanks both Michael and James for sharing your lived experience. That's so great. So that I would like to open the floor to questions. I saw that we did already get a couple in the Q&A. It's like one has already been answered, but yeah, floor is open. And Dr. Kosman and or Mounzer, did you want to answer any of the open questions live?
Yeah, I'm happy to. Should we read the question first for our audience?
That would be helpful, Dr. Mounzer.
Yeah. So one of the questions we received, and thank you for asking this question, is this is someone with a history of substance use disorder, 20 years now, and unfortunately, it sounds like they have a heart condition that preclude them from using methadone because of QT prolongation. So methadone is notorious in that regard, that it can cause QT prolongation, which is kind of like an electric abnormality in the heart, kind of like electric cycle, which could put the patient at risk for fatal arrhythmias called torsade de pointe, where the heart kind of like start defibrillating and then they can have a cardiac arrest. So this is kind of potentially a serious complication, a serious arrhythmia that can affect people with prolonged QT. And there are a bunch of drugs that increase the QT interval, we call it. So methadone is dose dependent, and it can do that. That's why certain individual after a certain dose of methadone should get, regular EKG to monitor their QTC interval. So apparently they are in their 50s, now 60s, and they were put on Suboxone for pain management because they have very severe avascular necrosis of their hip, which is pretty painful condition. And the question is, the Suboxone is not doing the trick. Is there anything that can be suggested? And I mean, one important question when it comes to AVN is, usually among people living with HIV who have AVN, we end by recommending at the end really total hip replacement, which is the ultimate. It's a curative and therapeutic intervention because it really can impact the quality of life immensely, and it can reverse to almost 90% their pain. So that would be my suggestion. Is a surgical intervention where they undergo total hip replacement. So that's my answer to this one. Personally, I'm not sure, Jay, if you have anything to add.
The only thing I would add, I think the questioner brings up a really important issue, which is the perception of chronic pain in people with a history of either injection or other substance use, and how that is dealt with. And I do think that's an important question. Trying to do other things to relieve the pain and using other approaches is, I think, very important. Dr. Mounzer pointed out one, which would be to be evaluated for hip replacement or surgery for that issue, because that it can avascular necrosis can be extremely painful, and I think the bigger point in that is to look for alternative approaches to pain control, whether it's surgery or whether it's other means to do that would be really helpful. So I think exploring those other approaches is really the best way to sort of approach that question in someone who is in the situation as you described them.
Yeah, the patient question had 5 replacements. So it sounds like they went through the surgical route to fix this problem. And in a situation like this, there's definitely pain clinics that we interact with at Penn and others. They have their own strategies in terms of how to alleviate pain, especially among individuals who had a history of opiate use disorder. So I would definitely connect my patient to pain clinics, and not any pain clinic, but pain clinics that we have a long-standing relationship with.
Thank you, Dr. Mounzer and Dr. Kosman, for answering that question. There was another comment that was posed in the Q&A box regarding your presentation, Dr. Mounzer, that if any of you who are watching, if you're interested in research and you're currently suppressed on antiviral therapy and taking methadone, Suboxone, or naltrexone, please reach out to Dr. Mounzer, Dr. Kosman, or FIGHT research staff to get involved. So this is an opportunity to become a part of research in this area, topic area. So reach out to Dr. Mounzer, Dr. Kosman, or the FIGHT research team to get involved, specific to Dr. Mounzer's presentation. Any other questions for the audience, or thoughts or comments you may have? We would love to hear from you. You can place that in the Q&A box as well.
I saw that there was also a question about why don't doctors use Suboxone or methadone to detox patients who are no longer allowed to receive pain medication? I just couldn't see the response to that. It just says the question was answered live, but I wasn't sure if it was if it had actually been spoken yet.
No, I think, yeah, in an attempt to answer that question, I'm afraid that I may have deleted it. So I'm glad you brought it up, Emily. And I think this is, a critical question, because the fact of the matter is Suboxone is indicated exactly for these reasons. And we should not hesitate to contemplate, the use of Suboxone for individuals exactly who have had a history of substance use disorder, opiates use disorder, and who are being tapered off, and who kind of like requirements. It's a very effective pharmacologic intervention where the risks, when you weigh the risks and the benefit, there's no question that the benefits outweighs the risks. And if it's implemented properly, it can help patients gain back their lives, because they are consumed by that addiction, so they can refocus their life on matters that are important for them. And we can implement it in a very risk kind of like, in a very kind of like beneficial or risk benefit cost effective approach. So I think it's important to consider we need to encourage our colleagues to get that ability of prescribing Suboxone, because they kind of like, they may have to go through, and that's something you can comment on, Emily, but there may be a small process they have to go through, but Suboxone should be part of primary care and not anything that's unique, because you know what? Substance use disorder is an illness like any other chronic disease. It happened to affect the brain and brain behaviors, and it should be treated like any other illness. So it's important that clinicians kind of like are open-minded to that. So.
And Dr. Mounzer, just a question for me. Based on your presentation, would you say that for this type of situation, people who are no longer allowed to receive pain medication and wanting to detox with either Suboxone or methadone, would you say that if they are living with HIV, that Suboxone would then be the better choice?
Yeah, so that's the whole question, correct? We're trying to literally answer this question in a very scientific and critical way. And that's why we're doing the study we're doing, to specifically look at individuals who are on different modality of substance use disorder treatment, trying to figure out which is the modality that has the least amount of immune activation, which is notorious, versus the modality that has the highest amount of immune activation. So if we think immune activation is a function of the degree of immune receptor stimulation, because that's what's driving really that GI dysbiosis and microbiome imbalance in bacterial translocation. If we think that's the case, then yeah, if you follow that logic, naltrexone would be the best choice, followed by Suboxone, followed by methadone. So methadone will be the least attractive option. And so that's how you would put it. But again, doing the study is critical, and that's why we would love to be able to kind of like complete and answer that question as soon as possible, because it does have an important impact on the lives of people living with HIV.
Thanks so much for that, Dr. Mounzer. Are there other questions from the audience?
If there's any other questions, do you have any last thoughts that you like to leave with the audience before we end today's presentation? So, since there isn't any other questions and our presenters have shared and answered questions, and if you have further thoughts or questions that you may think of later, feel free to reach out to Dr. Mounzer, or in fact, you can actually email Cheetah at site.org and pose your questions, and I can ensure that Dr. Mounzer, Dr. Kostman, and Emily can receive those questions to answer them if you have thoughts after today's presentations. I think I saw something pop up in the box. Someone said, "Great presentation. It was very helpful. Thank you, everyone." If there isn't anything else, we can end today's webinar. I'd like to thank you again for sharing on this important topic matter. I'm sure there are a lot of thoughts people may have about rethinking treatment for substance abuse and HIV. So thank you for sharing on this topic matter for us to kind of think about our approaches and perspectives. So without further ado, I'm going to end today's presentation. For those who are watching, join us tomorrow for our presentation at 11 a.m. Check out our website to see our other offerings for the remainder of this week. Thank you for joining us today, and have a great rest of your afternoon. Take care.
Thank you.
Have a nice.